Once activated, the proton pump inhibitors bind to exposed amino acids in the proton pump. Which amino acids are involved? We have serine, cysteine, lysine, and histidine. Okay. The chat box is saying B. Anything that we need to highlight about proton pump inhibitors? Maybe the adverse effects? That is notable.
Okay, maybe I'll say they are prodrugs, and then they're converted now to the active, is it sulfonilic acid? It now has a sulfur, and then now it forms a disulfide bond with cysteine, forming that bond that cannot be broken now.
Which means it cannot be broken, so they're irreversible.
Yeah.
Then minor side effects would be headache, dizziness, rash, diarrhea, nausea, flatulence. So a lot of the short-term side effects have to do with the GI, and then long-term usage may lead to chronic kidney disease, bone fractures, vitamin B12 deficiency, pneumonia.
Okay.
Yeah.
I think that's good.
Okay.
Scroll the screen, please. Oh, Trinidad, are we going up?
Yes, you start. The next one is 166.
Okay. What is the name given to the chemical that is chiefly responsible for biological activity of a natural extract? So we have a lead compound, we have a pharmacophore, active principle, and a lead principle. So we can get definitions of all this. What's a lead compound? What's a pharmacophore? What's a lead principle? What's an active
So a pharmacophore
and
is
even
the part of
loxophore.
a pharmacophore is the part of a molecular structure that is responsible for a particular or biological or pharmacological interaction that it undergoes. So basically, it's what ensures that the drug undergoes the interactions with like the specific biological target.
Okay. What's a lead compound?
A lead compound. So this in drug discovery, it's a chemical compound that has pharmacological or biological activity that's likely to be therapeutically useful.
An active principle and a lead principle. So active principles or medicinal principles of plants are substances found in plants that exert a physiological or a nutritive function in the body. How different is that from a lead principle? Or is a lead principle the same thing as a lead compound? Let us psych up keyboard warriors, bana. Keyboard warriors. Sophia. Okay, I think we can find if anyone finds anything, they can post it in the group chat or in the chat box. But more or less, we have found the definition. The answer is active principle. Number 165, regarding the analgesic activity of 3-acetylmorphine compared to diamorphine and 6-acetylmorphine, which statement is true? So 3-acetylmorphine is more active than 6-acetylmorphine and diamorphine. 3-acetylmorphine is less active than 6-acetylmorphine and diamorphine. 3-acetylmorphine is more active than 6-acetylmorphine and less active than diamorphine. 3-acetylmorphine is less active than 6-acetylmorphine and more active than diamorphine. So I think this takes us back to what are these molecules called? Conjugates. The roles that they play in structures. So 3-acetyl, 6-acetyl, and diamorphine on the structures. We can have someone post even the diagrams, representations of these 3 molecules so that someone can explain it better.
Okay, just one point. It says acetylation at 6 hydroxyl group increases activity. So since acetylation now increases activity, maybe the 3-acetyl and the 6 are more than the dimorphine. Yeah, that's all I have to say. So those people who are good in chemistry can explain to us the differences in the pictures and
Where are our chemists? Mm-hmm. Shrina, please, you can you explain the diagrams?
I don't know the explanation, but that is what I found.
Okay, so basing off what we have, okay, it has a relatively weak affinity to murine opioid receptors due to acetyl group in the third position, and it is less active than diamorphine and 5-acetylmorphine. Okay. So 3-acetylmorphine is less active than 6-acetylmorphine and diamorphine. Okay. Diamorphine should be the strongest, no?
Yeah,
Okay.
Moving with the strongest. Yeah, I've I found something I'll share also the same.
Okay.
Yeah.
Which structural modification is used to obtain beta adrenoceptor selectivity for adrenergic agonists? So in a naphthalene ring, introduction of a bulk N-alkyl substituent, removal of one of the critical hydroxyl groups, addition of an alpha methyl group to the carbon bearing the amine. So what is the effect of a naphthalene ring?
Daktari, pharmaceutical chemistry tulinyeshewa tangu third year sasa.
Yeah, I know. Everyone is just suffering.
Silence nini nijua hatujui.
What to do? What do we do without them?
We can just check, at least we know the answers to this one, just in case.
So anyway, what is the structural modification used to obtain beta adrenergic selectivity for the agonists? At least someone mentioned at least adrenergic agonists examples.
So I've seen here substitutions on the terminal nitrogen, that the primary and secondary amines have good adrenergic activity, and tertiary amines and quaternary ammonium salts do not have adrenergic activity. So nature of the substituents on the terminal nitrogen greatly affect beta 2 receptor selectivity and also beta 1, such that substitution with aryl alkyl groups, that is like aryl alkyl groups, provides compounds with selectivity and improved cellular penetration due to higher lipophilicity. An example I've found is formoterol and salmeterol. So you can check out the structure of formoterol and salmeterol to appreciate the terminal nitrogen substitution.
Okay, so terminal nitrogen is substitution. So yeah, definitely introduction of a bulk and alkyl substituent. So the terminal nitrogen will be given an alkyl substituent that will improve selectivity. Tetracyclines act as intercalating. Tetracyclines act as intercalating anti-cancer agents. Which of the following is a simplified analog of anti-cancer tetracycline? So daunorubicin is which class of anti-cancer?
It's an antibiotic.
An antibiotic. What about vincristine?
Zinc alkaloid.
And tenofoside? Basically, can someone take us through anti-cancer classes in like a minute or 30 seconds? Epipodophyllotoxin, okay. Can someone take us through briefly, maybe in 30 seconds or so, classes of anti-cancers? Platinum analogs, vinca alkaloids. Dr. Anita?
Okay, so we have vinca alkaloids, which is vincristine and vinblastine. Those are microtubule inhibitors. And then we have taxanes, which is paclitaxel and docetaxel. And then we have antibiotics, which is dactinomycin. So they end with either mycin or bicin. So daunorubicin, dactinomycin, doxorubicin. And then we have alkylating agents, which is the ifosfamide, cisplatin, oxaliplatin. So they end with the platins and also the mides. So isosfamide, cyclophosphamide. And then we have antimetabolites, which are methotrexate and 6-mecatopurin. And then we have cytarabine and capecitabine. So those are the 5 FUs. And then we have the camptothecin analogs, which is the topotecan and the irinotecan. So I don't know where teniposide lands. Is it an alkylating agent?
It's an epipodophyllotoxin.
Yeah. Something else, maybe something to note about toxicities, common toxicities due to vinca alkaloids. We can just mention 1 or 2 as we go. Neuropathy, That's a common one. Between vincristine and vinblastine, which has more neuropathy? Vincristine, thank you. Antimetabolites, methotrexate, a common side effect. Bone marrow suppression. Anything else? Yes, you're supposed to give folic acid to prevent deficiency that might arise from methotrexate administration. Cisplatin and other platins, a common side effect. More or less a dose limiting side effect will be nephrotoxicity. Okay. I don't know what else. What else can we think about? Autotoxicity, thrombocytopenia with carboplatin. Good. Anyone that is cardiotoxic? Okay, keyboard warriors are up. Okay, so carboplatin, thrombocytopenia, bleomycin, pulmonary toxicity, hemorrhagic cystitis with cyclophosphamide. That is very good to remember. Okay, anthracyclines. An example is doxorubicin. So yeah, maybe we can read about management of nausea and vomiting, chemotherapy induced. And I think, yeah, that. So the major classes we have been told that are those alkylating agents, antibiotics, taxanes, vinca alkaloids, antimetabolites. So alkylating agents are many. Cyclophosphamide can be there. The platinum agents are going to be there. Okay, pretty much. I think we are good. Anyone has anything to say? Good. Mesna. Mesna is used as an antidote to cyclophosphamide. Specifically cystitis due to cyclophosphamide. There's a question. Alopecia. What causes alopecia? Which drug will cause alopecia? Yes, all anti-cancers generally because of their mode of action. Their mode of action, most of the time they're going to attack. I'm not sure of what to say about that, but they're going to attack generative cells most of the time. So you're going to find loss of hair and even epithelial thinning and irritation. Thank you. So it's more or less methotrexate. Okay, Hiral is saying paclitaxel is going to cause total body alopecia, so maybe that would be unique. Cyclophosphamide, doxorubicin, vincristine, and methotrexate will cause alopecia as well. So maybe just not paclitaxel. I don't know if that is unique to paclitaxel. But yeah, I think it's good to know. Hiral, is it unique? Is total body alopecia unique to paclitaxel?
Yes, like unique to taxanes, yeah.
Okay.
To
Okay.
taxane,
So
yeah.
Okay, thank you. Dose of chemo calculated using, but yes, body surface area of the person. That is in dosing.
For the
Okay.
dosing, I think carboplatin is the only one that is you calculate the dose using area under the curve, something like that. I can't really remember. I know carboplatin has a different dosing range. I don't know if anybody can remember that.
Yeah,
Can
it's called the
someone?
Calvert. It's
Yeah,
calculated
yeah,
the
that one.
Calvert formula.
Yeah, the curve.
Carboplatin.
Yes.
Okay. AUC. Okay, thank you. Thank you for corroborating that. Doxorubicin is bad for the bones because it also causes low platelets. Dr. Anita, can you unmute? I don't understand reading that.
There are two different, you've read it as one sentence. So doxorubicin is bad for the bone and it also causes low platelets. It
Okay.
also causes low WBCs and RBCs.
Okay. Thank you. Has anyone anything more to say? Okay, good. So we've decided the answer. Okay, that's just the formula, the Calvert formula. Okay. So yeah, mitoxantron. Which of the following statements is true for non-nucleoside reverse transcriptase inhibitors? They cannot be used alongside nucleoside reverse transcriptase inhibitors. They bind to allosteric an allosteric binding site. Resistance can arise due to a mutation where the asparagine in the target binding site is mutated to lysine. Binding interaction between NRTIs and the main protein chain in the binding site are not important. B, can you unmute and elucidate further?
I think NNRTIs bind to an allosteric site, while NRTIs bind to the active site. I'm not sure about that. Then for A, they are used together with NRTIs.
Mm.
Yeah.
Okay, yeah. I don't think we need to spend a lot of time there. Or anything, anyone has a question there? If you do, please don't hesitate to raise it. All the following drugs act through inhibition of biochemical pathways except? So omeprazole. What is the mode of action for omeprazole? Have we covered HIV? I'm not sure. Have we? Okay. Does Hiral, do we need to go through it kidogo? Just a little bit?
Yes, we can go through. We can go through it.
Okay.
Anybody that can take us through, because I'm not sure myself. Especially
So
treatment and yeah.
yeah. So maybe just to remind us, kidogo, I don't know, someone will have to take us through the protocols for HIV. I mean, that is the guidelines for HIV, but more or less, just to remind us shortly, The classes of anti-HIV drugs, we have the nucleoside reverse transcriptase inhibitors, the non-nucleoside reverse transcriptase inhibitors. We have the protease inhibitors. We have entry inhibitors and integrase inhibitors. So integrase inhibitors, we have dolutegravir, which is, I think, the most common that we find in our setting, and raltegravir. The entry inhibitors will be infudvitide and meraviroc. Protease inhibitors, atazanavir, ritonavir, and darunavir. And then NRTIs, abacavir, emtricitabine, lamivudine, tenofovir, and NRTIs are going to be efavirenz, nevirapine. And just to note that monotherapy with NRTIs is going to hasten resistance to medication, which is what is making resistance. Sorry, there's nothing more to add to that. Anyone who can take us through the protocols?
Maybe before the protocols, I think the protocols, Dr. Guys can take us through that. A summary. So I wanted to mention the goals of antiretroviral treatment. There are like 5 goals, but the most main ones are the clinical goal. The clinical goal, the main role is to like decrease the opportunistic infections and improve the quality of life of the person. And then there's the virological goal, that's to decrease the viral load. And then immunological goal, that is to increase the CD4 cells. And therapeutic goal, that's to like decrease toxicity of the drugs, like not combining drugs that have the same, toxicity, like use a better for the individual person. And the 5th one is the epidemiological goal, that's to reduce the transmission and transmission of the HIV. So the 4 main ones are clinical goal, virological goal, immunological goal, and the therapeutic goal.
Thank you so much for
that. So to take you through the management, I don't know why you guys are always choosing me for these things like syphilis and HIV. Anyway, for HIV, I've resent the guidelines, the current guidelines. So first line we have the tenofovir, lamivudine, and dolutegravir. This is for adults. That's our first line regimen. Tenofovir, lamivudine, dolutegravir. But if a patient has kidney impairment, we know tenofovir does lead to renal impairment. We will substitute the tenofovir for abacavir. We'll substitute the tenofovir for abacavir. So the patient, instead of tenofovir, lamivudine, dolutegravir, they will take abacavir, lamivudine, dolutegravir. Then when we go to the pre-exposure prophylaxis, the patient would be taking 2 ARVs, that is tenofovir and emtricitabine, or tenofovir and lamivudine. That is according to the guideline. However, sometimes due to availability, patients on PrEP will just be given all the 3 as a patient who is HIV positive. So PrEP, it will be taken for as long as the person is at risk of exposure, Then for post-exposure prophylaxis, of course, within the first 72 hours, this patient must have started taking the ARVs. Typically, again, given the tenofovir, lamivudine, dolutegravir for 28 days to be taken faithfully, and then they'll be tested after 3 months to confirm that they're actually HIV negative. The other thing is prevention of mother-to-child transmission. So the first principle for prevention of mother-to-child transmission is the mother needs to be on her ARV meds, taking them
Hello?
with her ARV regimen. The child will be started on nevirapine and zidovudine for 6 weeks. Right, the first 6 weeks of life, that infant will be given zidovudine plus nevirapine. I'm assuming in this case the mother is breastfeeding, so think that the mother is breastfeeding. So the first 6 weeks of life, we will give zidovudine and nevirapine. Then after the 6 weeks, we will stop zidovudine and continue nevirapine until 6 weeks after the mother stops breastfeeding. So we know the minimum amount of time required is at least 6 months. So if the mother opts to stop at 6 months, we will give until 6 months and 6 weeks. But if the mother goes all the 2 years, we'll give and 2 years and until 2 years and 6 weeks, we'll continue nevirapine monotherapy. However, in the case that the mother does not breastfeed for one reason or the other, this is from the word go, the patient, the infant of this will just be given nevirapine and zidovudine for 6 weeks. Then again, we will stop the zidovudine and continue nevirapine for another 6 weeks, totaling the therapy to 12 weeks. Yeah, I think we've covered all. Prep, PEP. And if the child, if a child now, this is unique, or the sad part, if the child is HIV positive, because now, depending, we know when it comes to children, weight will play a role, that there'll be dosed based on weight. But now the first line drugs for children, it will be abacavir and lamivudine, abacavir, lamivudine, and dolutegravir, abacavir, lamivudine, and dolutegravir. This is for these children after 1 month who are HIV positive. Then between birth, if the child is born exposed to HIV and you did not prevent it from the word go, between birth to 4 weeks, they'll be given zidovudine, lamivudine, and nevirapine. Then after the 1 month, ABC, 3TC, DTG. Yeah.
Okay, for the difference that this question was covering, I've sent a photo to the group. So for NRTIs, they usually like their prodrugs, so they need a intracellular phosphorylation. And now the NNRTIs don't need, because they're not prodrugs. And so for the mechanism of action for NRTIs, they bind to the site, the what is it called? The DNA polymerase site. But for NNRTIs, they bind to allosteric site, as has been said. So when it binds to the allosteric site, it causes a conformational change in the site of DNA polymerase where the enzyme is binding. So the enzyme cannot bind there because the conformation has changed. And then for differences, also for the affinity to cause mitochondrial toxicity, for NRTIs, they have low affinity for DNA polymerase alpha and beta, but they have high affinity for DNA polymerase gamma. And the DNA polymerase gamma is the one for mitochondrial toxicity. So that's why we see in NRTIs, we have high mitochondrial toxicity. And for NNRTIs, we don't have, because they don't affect the DNA polymerase gamma.
Okay. Anyone else with anything to add on? Okay, thank you for that. All the following drugs act through inhibition of biochemical pathways except eflornithine, terbinafine, diclofenac, and omeprazole. I was asking, what is the mode of action for each of these? Diclofenac, COX inhibition. Terbinafine, squalene epoxidase inhibition. I think, have we gone through antifungals before? Someone can confirm. Eflornithine, you can just type in, please just type in the chat. You don't have to wait for me to shout it out. Ornithine decarboxylase. So the question is asking, all the following act through inhibition of a biochemical pathway, except, so that means basically a reaction, right? Omeprazole, we are seeing, we answered that it binds to, it irreversibly binds to the amino acid cysteine, right? Causing inhibition of the proton pump. Okay, so the activated form then binds covalently with the sulfhydryl groups of cysteines in this hydrogen potassium ATPase, irreversibly inactivating the pump. So it is not a biochemical pathway, it is more or less a site thing. Good. Which of the following isomers of quinine is an active antimalarial? What does an active antimalarial mean? What does that mean? Someone translate that. Active antimalarial. What does that mean? Has activity. Okay, maybe I'm overthinking it. Okay, has activity against Plasmodium parasites. Okay, maybe I'm overthinking it. Anyway, the answer is pretty obvious on that, right? Anything that we should mention on that? Anyone has anything you should mention on that? Quinine is 8S, 9R. Also, it's while quinidine is 8R, 9S. Then the opposite of synconine and synconidine. Oh, so synconine is 9R and 8S. And then synconidine will be 8S and 9R. Is that what you mean? Asmahan?
Yes.
Please
Yeah.
unmute. What?
Okay. Quinine is the 8S 9R, and then quinidine now is the HR9S. But then for synconin, it's going to be like quinidine, like HR9S, and then synconidine will be like quinine, HS9R.
Okay.
Yeah. The difference between quinine and quinine, quinidine, synconin, and synconidine ni just that kina quinine iko na methoxy group, and then kina synconin iko na a hydrogen at that position. I'm not sure at which position exactly, but from what I remember is that kina quinine and synconidine is like quinine ziko na a quinoline and a quinacridine ring. So hiyo difference inakuwa at the quinoline ring, but siko sure at which position exactly. Yeah.
Okay, thank you. There is a question on the chat. Antimalarial activity of drugs at each stage of parasite development. Yes, please, anyone. So stages, Plasmodium life cycle. First of all, important things to note about the life cycle. Or rather, what is the infective stage of a Plasmodium in a human being? Let me volunteer Baraza.
Yes, what's up?
Yeah, anything. Life cycle. Can you take us through the a brief summary of the life cycle of Plasmodium?
Unless I have to just check it out.
Yeah, you can check it out. You can check it out and just take us through it. It's no problem.
Okay. Or if anyone has found it, they can share a picture on the wall so that I can take you through
Yeah,
it.
it's there already. It's on the chat.
And now basically, we have the trophozoites, the schizones, and the merozoites. So once injected in the blood, the Anopheles mosquito introduces the gametocytes in the blood. No, the bite injects sporozoites into the host, and then the sporozoites in blood move to the liver. Hepatocytes are infected by the sporozoites that mature to schizones, and these schizones then rupture and release merozoites. So we are starting with the bite that is introducing sporozoites, Sporozoites in the blood move to the liver. Then in the hepatocytes, the sporozoites mature to schizones, which now rupture and are released as merozoites. Now, the released merozoites then infect the erythrocytes. Then gametocytes mature in infected erythrocytes and are released into the blood. So after that, the mosquito again ingests the gametocytes, and the male gametocytes are called microgametocytes, and then the female ones are called macrogametocytes. So this is the mosquito again ingesting them, and then after it ingests them, it will again infect maybe someone else. So the stage will repeat itself. So basically, we'll start with the sporozoites, move to the liver, they mature to schizones, and then they are released as merozoites. The merozoites are the ones that infect the erythrocytes. And you also know that in the erythrocytes, we shall have gametocytes, which will mature again. And once you're bitten by the mosquito, it can infect someone else after ingesting the gametocytes. So basically, that's it.
Okay, good. So basically, to note, there are three stages. There's the gametocyte stage, which happens. It's more or less in the Anopheles gut. Then there's the liver stage, and then there's a blood stage. Basically, the drugs, gametocidal drugs, they're primaquine and artemisinins. Those that will kill at the liver stage, atovaquone and primaquine. Those that will kill in the blood stage, that is a schizonticidal drugs, artemisinins, antifolates, antimicrobials, quinolones, and primaquine, which means, so what is going to cause the different kinds of malaria? I'm forgetting those two terms, please. Someone remind me. The one that is stored in the liver where
I think you mean to talk about recrudescence and
yes.
relapse.
Thank you. Recrudescence and relapse. So which parasite strains are going to cause recrudescence?
Recrudescence is P. malariae, that is Plasmodium malariae, and Plasmodium vivax. No, P. malariae causes the recrudescence stage.
And relapse is
P. vivax and P. ovale.
okay.
Yeah.
Anything else? Amesema hypnozoids, yeah, dormant liver stage. Those are going to be called hypnozoids. Anything else? Anyone has anything else to say? Okay, first line treatment of malaria. Oh, that is uncomplicated malaria. First line treatment of uncomplicated malaria, probably in pregnant women and normally. L combination. Okay. Anything else someone has to say? Uncomplicated malaria. What is uncomplicated malaria? What is complicated malaria? Sorry. How do we treat complicated malaria? Anything to note about quinine, black water fever?
In complicated, you said complicated malaria
Yes, complicated malaria. What is it? Treatment?
management.
Yes.
The management.
Yes.
The first line. We have artesunate, which is given according to the body weight of the patient, and the body weight, if the weight is above 20 kgs, it's normally given 2.4 per kg, and if it's below 20 kgs, it is given 3 milligram per kg, and you give until the patient is able to take orally. That is, they are able to contain. After you give immediately you started, you give for at least 24 hours with the start dose, then another dose at 12 hours, another one at 24. Then for the oral, if they are able to take oral, you give 12 hours after the last dose of artesunate. If they are not able to take, you will be giving OD until they are able to take orals. The orals that is given for the management is artemether lumefantrine, which again is given according to body weight.
Okay. So that's why I was asking what does, because you see the question that has come. Is malaria in pregnancy considered complicated? No, not necessarily. Complicated malaria is when maybe there is associated, I would say, organ damage or complications to some sort of organ in the body. So maybe liver or the brain, where you're going to get something like cerebral malaria or something like that. That is when we are calling it complicated malaria, not necessarily because of pregnancy. In pregnancy, the first line I think is L or quinine. I'm not sure. Can someone remind me?
In pregnancy, it depends whether it is severe malaria or it is uncomplicated.
Yeah.
In this case, if it's severe, you start with the artesunate. That's the way I've said it. Then the most preferred is quinine. Quinine tablets, which is normally given, is it 600 milligram TDS for at least 5 days. But you find most of them are not able to contain. But if a patient is able to contain, the most preferred is quinine. But you advise on taking the oral glucose. And if they're not able to contain, you cannot hold on AL. You can give AL. Initially, AL they were ruling out using AL in first trimester, but currently it's being used if in the absence of quinine.
Okay, thank you.
Again, to note, we give IPT. We normally give IPT in malaria endemic areas.
Yes.
Yeah.
What is the drug used in IPTP?
We give SP, and SP you give you start giving at 13th week, and when giving SP, you take caution with the folic strength, the folic strength.
Okay, thank you. I think that's it. Anything else? Anyone has a question about malaria? Good. So the following drug pairs are classical isosteres, except someone can define isosteres in the chart. So estradiol and diethyl stilbestrol, chloramphenicol and thiamphenicol, lovastatin and atorvastatin, halofantrin and lumefantrine. The following drug pairs are classical isosteres, except someone can define isosteres in the chat box. What is isosterism? Isosteres are atoms, molecules, or ions of similar size containing the same number of atoms and valence electrons. Who can help us out?
Asma.
Okay, someone was saying something? Sunshine is saying different atoms with same activity. Has anyone to say anything here?
Hello.
Yes.
So from what I remember, with an isostere, it's like on the functional group. So let's say you have an amino. Can you replace like the amino with another heteroatom and get the same activity? So we can replace the amino with something like an NO2, or maybe just get a different heteroatom, but will give you the same level of activity. So I think I could agree with A, because estradiol, this is natural, has an alkene portion, and the ethyl stilbestrol doesn't. So I might agree with A.
Okay. I don't know about the structures of lovastatin and atorvastatin, but okay. Anyone else? I will move to the next thing. Okay. All the following are structure-based drug design strategies except in silico studies, molecular modeling, receptor mapping, and serendipity. I think that's pretty obvious, right? Serendipitous discovery is more what luck, perchance happening. Someone has anything to say about drug design? Computer aided drug design. Someone remind us about in silico studies. I think I'm going to volunteer someone. It's either help us. Sam, please.
Okay, so computer-aided drug design is basically whereby we're trying to conduct drug discovery using computational methods. So we usually have two types of computer-aided drug design. Okay, we have or in silico drug design, you have what you call the ligand-based drug design and the target-based drug design. So in ligand-based drug design, what we do is we identify a molecule. For example, it's aspirin. Then we go to online databases such as Similarity, and we identify basically molecules which are identical or similar to structure with acetyl salicylic acid, with the notion that similar structures might have similar modes of action. Basically, they might interact with the same receptors. In target-based drug discovery, we first identify the target, that is usually the receptor that is of interest to us. After you've identified that particular receptor, then you try and find molecules which can actually bind to that particular target and bring about a desired action. If you find targets which have good docking scores or which bind to your receptor in a good way, then you set them aside and then you take them for further research. So usually, they usually combine both methods in the computational drug design to achieve better results. Yeah, I think that is just a general summary for you guys.
Okay. Anyone has a question? You can always write it down or unmute. Which of the following is a structurally non-specific drug? So sulfamethoxazole, halothane, atenolol, and paroxetine. Structurally non-specific drug. Someone translate that in simple English. Willy. So structural non-specific drugs are those whose pharmacological action is not directly dependent on the chemical structure of the drug, except that structure affects physicochemical properties. So pharmacological action is not directly dependent on the chemical structure of the drug. Okay. So what is our reasonable answer here then? So a drug that has no specific site to bind with in order to exert its pharmacological effect, such as gases, anesthetics, and disinfectants. Okay, so gaseous anesthetics. Okay, so B, halothane. I think we are in agreement. We have gone through drug tolerance. We have defined it before us. Thank you. As a decreased responsiveness upon repeated exposure. How did you differentiate this with the tachyphylaxis?
I think we said that tachyphylaxis is acute, while tolerance is more chronic in terms of the time period. So tachyphylaxis happens rapidly, while drug tolerance takes time.
Okay. The phenomenon where the pharmacological effect of two drugs administered concurrently is less than expected is called. Have we answered this before? Okay, the phenomenon where the pharmacological effect of two drugs administered concurrently is less than expected is called. Okay. Anyone maybe wants to redefine what synergism, concordance, and complacence mean? Or we move to the next. Okay. I'll take that as a yes. Dose adjustment of drugs among the elderly is recommended mainly due to poor gastrointestinal absorption, loss of lean mass, reduced hepatic drug metabolism, and reduced renal clearance. Dose adjustments of drugs among the elderly is recommended mainly due to yeah, that makes more sense. In kids or pediatrics is going to be maybe developmental issues, maturity. Severe obesity may alter drug kinetics in the following ways, except distribution of a highly lipid soluble drug, a loading dose of a drug, absorption, glomerular filtration. Severe obesity may alter drug kinetics in the following ways, except distribution, loading dose requirement, absorption of the drug, or glomerular filtration. I'm going to have to volunteer someone else. Lydia Wesonga.
Yes.
Yes, please help us understand and choose a good option here. Severe obesity may alter drug kinetics in the following ways, except so the effects of obesity. Distribution
So
of lipid.
I'm sure
Mhm.
with option A and B are right. When severe obesity means you have a lot of body fat, means the drug, for highly lipid drug, they will have high volume of distribution into the body fat, and loading dose of a drug will be affected because the loading dose depends on the volume of distribution. That means when you have a high volume of distribution, meaning the loading dose will be high. And then absorption of the drug and glomerular filtration, I'm not sure. So someone maybe can explain that.
Okay, thank you. We are left with option C and D, absorption of a drug and glomerular filtration. Yeah, absorption increases with obesity. Hiral, you can help us reason through C and D.
Okay, since absorption increases with obesity, then that would also be correct. So I'd go for D. Although I'm seeing over here that obesity can affect renal and hepatic function, which may impact drug clearance and prolong the drug's presence in the body. So I'm not too sure.
Does obesity increase absorption? Oh, hey, Hello is saying he'd go with the load. Why? Hello, you can unmute or type further.
Because the other choices remaining there are basically the pharmacokinetics, distribution, absorption, and elimination. Yeah, so loading dose seems like the odd one.
I can explain the loading dose. If you find the formula for the loading dose is directly proportional to the volume of distribution. And in the first choice, we said the volume of distribution will be high in the obese patients because they have more body fats, meaning high volume of distribution will lead to high loading dose in severe obesity. So I think A and B are related. So maybe, don't know.
Wait.
But I think
Yeah,
So-
loading dose.
Volume of
Loading
distribution.
dose depends on volume of distribution. So yeah, an obese patient will have a high volume of distribution.
For option D on glomerular filtration, it says that glomerular filtration is dependent on the muscle mass. Even when you check the test for filtration, we check at the creatinine levels. So in obese patients, I think mass is very small, so we shall have an effect on glomerular filtration. So I don't think D can affect, like obesity can affect glomerular filtration.
Absorption. I'm not sure. I'm not so sure about absorption. What do you mean absorption? How is obesity and absorption related? Glomerular hyperfiltration is observed in severe obesity. Good. how is absorption related to obesity? Because if absorption, we're basically talking about the drug moving from the stomach compartment into the blood. Is obesity affecting that?
I think obesity.
You can think about the oily preparation for IM injection in that line.
Pardon, you can explain that?
Like if you have a lot of adipose tissues, the drug will sit in the adipose tissue and will not be available for systemic circulation. Or will not be available in the systemic circulation.
But isn't that after absorption? So how is absorption does changes in GIT motility and blood flow, thus leading to delay in drug absorption?
Oh.
Are there really changes in GIT motility in obesity?
Someone has shared something in the group,
Okay.
and absorption is the correct choice. That it's not affected by obesity. Let me just read what she has shared.
Okay.
She has shared that absorption and bioavailability, they're not altered by obesity. I think the correct choice is absorption.
Absorption. Yeah. Absorption would make more sense.
But then
Are we on
I
board?
was seeing now when I'm wondering when you're talking about drug kinetics, aren't we saying that we're looking at the absorption, distribution, metabolism, and excretion? So here I found that obesity can modify the distribution of drugs administered through the skin and subcutaneously. That's one. And then two, when you look at insulin in itself, it causes lipodystrophy. And that's because the insulin stays within that area and refuses to redistribute to the rest of the body. So I'm wondering, isn't that something which is associated with, first of all, severe obesity and now the drug kinetics in themselves? Especially when you're giving drugs subcutaneously.
I think in that case, it is less to do with absorption and more to do with the distribution. I don't know, but I tend to think that a lipodystrophy due to insulin is more to do with that. It's more of a distribution issue than an absorption issue.
So are there any like physiological or anatomical changes that happens in the GIT due to obesity? Because if there are, maybe to cope with the large intake of the calorie intake, and that would mean it also affects absorption.
No, there are no changes in the GIT in obesity. It remains the same.
Okay, allow me to read something here, please. Obesity can alter the rate and absorption of medications, especially those that are lipophilic. It may change the depth of both the skin and subcutaneous tissue layer.
I don't know what I'm thinking that we might have to go with the best option that we have. Severe obesity, we have said, is associated with an increased glomerular filtration, if what is read. Yes, so there's glomerular hyperfiltration in severe obesity. We know that when you increase the body size, distribution is affected. And again, you're increasing the fat cells mass, the mass of the mass of your fat content. So distribution is affected. Of distribution of highly lipid soluble drugs, which means that drugs that, if they're supposed to get into the blood system, they're going to get stuck in the fat layer of the body. So definitely kinetics are affected. The loading dose, we have said it is associated with it is related to the volume of distribution as well.
I'm wondering,
yes.
You see, like here, all the other that we have dealing in it, all the other cases that we have something to do with the body in itself. But the loading dose is the only one which is just the same. And I'm thinking, when we adjust our loading dose, aren't we accounting for the different metabolism that people with more weight will have? So I don't think that the loading dose in itself is a characteristic in this question, because all the other choices that we have are related to our body function.
Kinetics.
Yeah.
Can we get a consensus? Ama we mark it off?
I guess most explanations have favored absorption to be the choice, but we can just mark it and then we proceed.
Okay. Which of the following is not a phase 2 drug reaction? That's pretty straightforward. Absolute bioavailability of a drug is achieved through which route of administration? Absolute bioavailability of a drug is achieved through which route of administration? That is also pretty straightforward, no? You're avoiding fast pass generally. So yeah, IV. Anyone has anything? I think we should move to the next. That is straightforward, no? Thank you. The most important organ for drug excretion is the liver, skin, kidney, lungs. The liver would be the answer if the question was.
Metabolism.
Thank you. Acidic drugs mainly bind to dash.
Albumin.
This is an either you know you don't. Is there any basic drugs then?
Alpha-1 acid glycoprotein.
Okay. Antagonists are drugs that occupy a receptor without activating the effectors, exert a pharmacological action, increase the number of receptors, cause disintegration of cells. That is straightforward, no? If there is anything you feel like we need to mention, I feel like there's some things we're just going to go through as fast. Which of the following statements is not true? Lipid-soluble drugs may cross the cell membrane and act at the cell nucleus. Drugs may cause conformation change of receptors. Drugs may interact through ligand-gated ion channels. Drugs are incapable of stimulating a protein. Which is not true? That is also straightforward. If you have anything, please be careful to note or speak out or write. All the following are long-acting benzodiazepines. So someone can give us those lists. Long-acting, short-acting benzodiazepines. And I think there is one that is shorter than short. I'm forgetting the term. Can someone mention them? List them? And maybe type it. Someone was talking? Yes, ultra short, short, and long acting. So ultra short is midazolam. I don't know that for sure. Someone has a list? I think I'm going to ask Abigail Soila. Please, do you have a list you can read out to us? Or we move on to the next question.
Let me see.
Okay,
Yes.
so the ultra short acting, yes, is midazolam. And then short acting for 3 to 8 hours, we have oxazepam and triazolam. And then intermediate acting for 10 to 20 hours, we have alprazolam and lorazepam. And then long acting, 1 to 3 days, diazepam and flurazepam.
Okay.
And, yeah, and clonazepam.
And clonazepam?
Yeah, long acting.
Okay. Okay. The one with the longest duration of action, or rather the longest half-life? Someone can type that in the chat. Let's move to 145. So lorazepam. Sedatives. Okay. Sedatives and hypnotics. Yes, yes, we can. if we don't get someone talking to us about sedatives and hypnotics, I'm volunteering someone. So Liz and Mr. Lova. Please. Bonaya. Anything, not necessarily all that is there to be known. Anything you can remember, recall, highlight about hypnotics, alternatives, sedatives.
Maybe just before they go ahead, lorazepam and oxazepam, they have a short duration of action because they have a hydroxyl substituent, and so they are excreted faster. So as a result, they have a short duration of action.
Okay, thank you. That is the pharmaceutical chemistry of it. Number 4, Abbas, anything. B.
I can say something about sedative and hypnotics.
Yes.
To start with, sedatives are drugs that produces calming or quietening effect and reducing excitement. It may not induce drowsiness. Sorry, it may induce drowsiness. Then for hypnotics, it is a drug that induces sleep resembling natural sleep.
Okay, thank you.
Okay, about the drugs, sedative hypnotics, we have benzodiazepines, we have barbiturates, miscellaneous agents, newer benzodiazepines. Benzodiazepines are classified under short acting, intermediate acting, and long acting, but I don't have the examples. You already have them. Barbiturates, we have also ultra short and long acting. And for miscellaneous, we have anxiolytics, that is buspirone, antidepressants. Then we have hypnotics, Z drugs, antihistamines, dozepines. For newer benzodiazepines, we have zopiclone and zolpidem. Thank you.
Thank you. Thank you. Anything else from anyone else?
Okay, another difference like between barbiturates and benzodiazepines is that for barbiturates, usually at high doses, they'll move towards coma, but then for benzodiazepines, as if we get to the coma level, usually we start with sedation, then hypnosis, then anesthesia, then we move to coma. But then for benzodiazepines, it's a plateau at the anesthesia level has to proceed to coma because these barbiturates usually have, okay, at high doses, they usually have a GABA mimetic activity. So they lead to coma at high doses. But then for benzodiazepine, hazina hiyo GABA mimetic activity at high doses. So zina plateau at anesthesia. So ndio maana benzodiazepines are usually the drug of choice for patients with insomnia rather than barbiturates juu zinaweza lead to coma. Yeah,
Okay,
that's it.
thank you so much. Thank you. Marashi, Ali, anything? Edwards, EK. Anything, Felicia. The antidote to benzodiazepine is flumazenil. Good, thank you. Okay. I think we're good.
About the side effects or adverse effects of benzodiazepines, we have ataxia, hangover, tolerance, physical and psychological dependence, withdrawal symptoms, e.g. like rebound insomnia, anorexia, anxiety, agitation, tremors, and convulsions. Thank you.
Is tapering needed? For benzodiazepines?
Let me check. Yeah, of course, anything that has withdrawal symptoms, I think it is necessary. Yeah.
Thank you. Okay. Anything else? Liver impairment, you can give oxazepam and lorazepam. Okay. Okay. So we are at 145, right? All the following antimalarial drugs belong to the 8-aminoquinoline class, except primaquine, palmaquine, piperaquine, and tafenoquine. So quinolines, the chemistry of quinolines, can someone take us through that? SAR, classes. Hello.
I've sent the diagram to the group.
We do have chemists. I'm not one. You mind taking us through it slightly? Sorry, my network seems to be problematic. Do you mind taking us through the diagram, please?
For the classes of antimalarials.
Yes, if you can, the chemistry of it, just
Oh,
slightly.
you want the chemistry?
Yes,
That
just
one is the
slightly.
classes.
I
have the slides I can send. I
okay,
don't have a summary.
okay,
Yeah.
That is good. That is good.
Okay.
For the SARs of 8-aminoquinolines, the methoxy group at position, you can look at the diagram to make it more sense, for it to make more sense. So the amino group at position, the methoxy group at position 6, usually necessary. Uki replace the methoxy group, it loses activity. Na ukiweka a highlighted group, ina become toxic. Alafu the terminal amino group, I think it should be a primary group. Juu ukiweka a secondary or tertiary group in a lose activity. That's all I can remember.
Okay. So all the following antimalarial drugs belong to 8-aminoquinoline, except consensus answer ni gani?
C.
Okay. Those who are good at chemistry can teach us more or get us more summaries. All the following are non-sedating antihistamines except hydroxyzine, cetirizine, pirfenidine, stemizine.
Hydroxyzine.
Okay, that's a new. If you have any question,
By the
you can.
way,
Yes.
hydroxyzine is converted to cetirizine in the body.
Okay. Any question, anything, any concern, we can always speak up. All the following belong to the aryl propionic acid derivatives of NSAIDs except? Again, chemistry of NSAIDs. Anyone has a summary can help us through. Naproxen, mefenamic acid, ibuprofen, phenoprofen. Anyone with chemical classes of NSAIDs? Someone can take us through them briefly too, or even just mention the types of source originator acids or something like that.
For the chemistry of NSAIDs, I can remember the carboxylic acid is important for binding to the COX to the COX receptors. And then Asmahan has more to say about ibuprofen. Asmahan, please.
Okay. All I can remember for ibuprofen, apart from it having that carboxylic acid, it's that it's derived from, like, it has a propanoic acid moiety. Yeah, that's the carboxylic part of it. It's propanoic acid. Hiyo ndio nakumbuka about ibuprofen.
Okay, thank you. Kama chemistry inachapa watu maajabu hapo, so we are suffering. So the consensus answer is B. I don't know. I would want to, again, if someone can has that summary of just maybe even the aryl propionic, antranilic. I don't know what other acid is there or other groups are there, but if someone has a list or a diagram anaweza tuma kwa group ama ike kwa chat, or you can speak up. I literally have nothing to contribute to this. It's been sent. Someone can help us through it then. Dr. Tonui, you can just help us read through the thing. Just help us read through the thing.
Hello,
Yes.
can you hear me well?
Yes, I can hear you. I hope everyone else can.
Okay, so I'm just going to read through.
Yes.
The selective COX-2 inhibitors, the coxibs. So celecoxib, etoricoxib. Yes, then the preferential COX-2 inhibitors, nimesulide, diclofenac, aceclofenac, meloxicam. Then, under the non-selective COX inhibitors, we have the para-aminophenol derivatives like paracetamol, then the salicylates like aspirin, the propionic acid derivatives like ibuprofen, ketoprofen, naproxen, then the phenamates like mefenamic acid, the enolic acid derivatives, piroxicam, tenoxicam, then the acetic acid derivatives like ketorolac, indomethacin, then the pyrazolone like phenylbutazone. So it's just worth noting that meloxicam does not belong to the enolic acid like piroxicam and tenoxicam. It's a COX-2 inhibitor. Yeah.
Okay. Thank you. We can go through that drug, and of course not the for salicylates, the active moiety is the salicylate ion, reducing acidity, maintains analgesic activity, but eliminates anti-inflammatory activity. Reducing the acidity of salicylates will maintain analgesic activity, but will eliminate anti-inflammatory activity. I think that is a good MCQ there. Thank you, B. Thank you. Okay, so all the following antilipidemic drugs are hydromethyl CoA inhibitors except atorvastatin, lovastatin, tetrahydrolipostatin, and serivastatin. Antilipidemic drugs. Some. Hasna is saying C. Hasna, can you take us through antilipidemic drugs? Anything you know, anything you don't. Hasna, anything you remember about antilipidemic drugs? The classes we have maybe.
You remember niacin increases HDL.
Can you, anything? Our host, anything about antilipidemic drugs, the classes, briefly?
Okay, so
Yes,
the
we have,
classes. I'll let Amim to go ahead.
yeah, classification, we have HMG, CoA reductase inhibitors, example are statins, like simvastatin or whatever it is, atorvastatin. Then we have bile acid sequestrants, resins, we have cholestyramine, and that's all I have. I have short notes, but not complete.
Okay. Host.
Addition on the classes,
Mm-hmm.
we have niacin, we have the fibrates, we have the cholesterol absorption inhibitors, and the omega-3 fatty acids. Yes, that's all.
Host was talking.
And the
Which,
cholesterol absorption inhibitors, like dietary cholesterol absorption is
pardon?
inhibited. Like the ones that inhibit dietary absorption of cholesterol, like ezetimibe.
Yeah, I think they've said it all.
Yeah, they have. They have. Okay, good. Types of lipoproteins. So HDL, VLDL, LDL. Who can take us through those and what they mean, at least clinically? Dr. Ntwiga?
Hey, which number are you? I'm lost.
We are at number 142, but we are asking about types of lipoproteins and maybe their clinical significance.
Okay. Okay.
Okay, just I'll give my short summary. Someone can add. Let's start with what Dr. Hasna is saying. HDL is anti-arthrogenic and LDL is arthrogenic. I shouldn't have started with that. I don't know what arthrogenic means. Like forming clots. Anyway, the classification of lipoproteins, we have 5. We have the chylomicrons or chylomicrons. We have the very low density lipoproteins, intermediate density lipoproteins, low density lipoproteins, and the high density lipoproteins. So clinically, LDL and HDL are the common focus. LDL, bad. HDL, good. So we'll start by looking at them. So for LDL, what LDL does, and that's the reason we call it the bad cholesterol. LDL, or rather, no, let's start with HDL. HDL, what it does, that's the reason we call it the good cholesterol, is that HDL will take will transport cholesterol from the peripheral tissues to the liver, to be broken down, to be used in the liver, you know. So HDL will take cholesterol, will transport cholesterol from the tissues to the liver, okay? Then, and HDL is our good cholesterol. You know, when it's in the liver, the cholesterol can be managed vizuri, or it can be broken down as it should. Now coming to LDL, which is our bad cholesterol, it's the one that will transport LDL now from, will transport cholesterol from the liver to the peripheral tissues, from the liver to the peripheral tissues. And we know somewhere along the way, if they get oxidized, or atherosclerotic plaques will form. That's why the term atherogenic makes sense now, makes sense. Yeah. Then when we go to the chylomicrons, those chylomicrons are the ones which transport your dietary triglycerides, what you eat, from the intestines to the adipose tissue for storage and to the muscles for energy. So when you eat your fatty food, the first type of lipoprotein that your fatty food will encounter is the chylomicrons. Chylomicrons will transport them from your intestines to the adipose tissues or to the muscles to be used. Then the very low density lipoproteins, these ones are synthesized in the liver, and I believe they will also function in the same way in that they will be transporting stuff to the peripheral tissues, but somewhere along the way they lose what? Very low density lipoproteins. Low density lipoproteins. I don't know what is it they lose that now they become now LDL. This someone can perhaps remind me of that. This because LDLs will be are also products of VLDL. Yeah.
Okay, thank you. Okay, any concern? Okay, I think we can move to the next. Which of the following adrenergic antagonists acts on both alpha and beta receptors? So that is non-selective.
Definitely carvedilol.
Thank you. Where is carvedilol primarily indicated?
It's hypertensive.
Yeah, but there is a preferential heart failure. Thank you. Thank you, guys. Preferential, I would say, indication for carvedilol. All the following are semisynthetic antibiotics except tigecycline, azithromycin, amikacin, lincomycin. So semisynthetic, so types of antibiotics, synthetic, someone can give us synthetic, natural, and semisynthetic. First of all, are they antimicrobial or are they antibiotics? What is antibiotic? What is antimicrobial?
I think antimicrobial includes fungi, bacteria, and viruses. I'm not sure.
Okay.
I have something to add.
Yes.
Antibiotics means strictly from microorganisms. And then antimicrobials includes both synthetic and from organisms.
Okay. Okay. Thank you. Thank you. So synthetic, or rather natural antibiotics, our natural antibiotics examples.
Kina penicillins,
Mm-hmm.
beta-lactam, I mean.
Are there any semisynthetic beta-lactams? Definitely no. Okay. I don't think we need to. Yes, amoxicillin is semisynthetic. So I don't think we need to spend much time there. We can move on to the next. I don't know how much time we have. When are you to stop? At 1. We can move to the next. According to the Hansch model for drug design, the biological activity of a molecule depends on the following parameters, except lipophilicity, size, electronic properties, and steric factor. Hansch model. What is Hansch model for drug design? We did this, right?
Yeah, so it's size.
Yeah, I think we've done this. Anyone has questions? Again, you can always pick up. Adulteration of drugs can be due to any of the following except collection during the wrong season, collection of the less important parts, collection of appropriate parts, collection of drugs from other species. Again, that is straightforward. Carica papaya, ananas, comosis, and ficus glabrota are plant sources of I literally would have just reasoned with carica papaya being used as meat softener or something like that. Enzymes. Papain,
Yes.
yes.
Papain.
Literally, that is the only thing I would have thought about. Okay. The following plant is a source of anti-cancer agents. Mytenus bishanani, Cypress rotundus, carica papaya, and Aloe barbadensis. We've said papain is from carica papaya. Aloe barbadensis will give us aloe gel, right? What is the active, rather the active, I would say, ingredient of the compound in aloe gel? It's their specific chemical. I'm a component. I feel like there is. I just can't remember. Barbaloin. Probably, I'm not sure, but probably yes.
Yeah, it contains also vitamins, enzymes, minerals, sugars, lignins, saponins, salicylic acid, and amino acids.
Okay. So which is the source of anti-cancer agents here? Someone can look it up.
Kwanza hiyo cyperus, it is used for diarrhea, diabetes, psoriasis, inflammation, malaria, and stomach and bowel disorders.
So it's like an antiviral, antibacterial kind of thing.
I have found somewhere that it's carica papaya because it has the beta coumarin and beta carotene.
Ah,
Yeah, that's from my notes. I hope they're correct.
Honor is saying the Mytenus bishanani is a worldwide distributed, is a worldwide small evergreen tree, traditionally used as anti-tumor, anti-ulcer, anti-inflammatory, and as antibacterial. Patel is saying Cyprus rotundus is used for leukemia. Okay. This again is a no. It's either you know you die, because it can be papaya again. You know, someone has said carica. Anyway, the following plants are potential sources of anti-HIV drugs except Castanospermum australis, Hyperica.
136.
We have decided on B. It looks like the most, I don't know.
But I've told you, I've checked from my notes, it's carica papaya.
Carica papaya.
Yes.
Honor is saying the maintenance, the choice A is also used as anti-tumor as well.
Okay, it's okay.
And Patel is saying B is used for leukemia. And I don't know. I feel like maybe the only thing that's odd one out here is the aloe one. In my view, maybe the question was not right. Right? Aloe looks odd to me out here. I have not seen aloe being used as an anti-cancer agent. Okay, yeah, you can mark that. Thank you. The following plants are potential sources of anti-HIV drugs, except Castanospermum australe, Hypericum perforatum, Centella asiatica, and Cucuma longa.
Before you proceed, can I read something about aloe also?
Yes.
Even though aloe or its compounds is known to play anti-cancer activities in many cancer types in vitro, few studies have reported this evidence. So it is not evidence, like it has not been ruled out, like it has anti-cancer activity.
So I don't know what they wanted here. Anyone has maybe a thought that can lead us to a decision? If not, we can just proceed. We can mark it and go, because clearly everything looks like
The same. Leave it.
okay. The following are potential sources of anti-HIV drugs, except Hypericum perforatum is used as an antidepressant, I think. Mm. Centella asiatica.
Curcuma has antiviral activity.
Curcuma has, okay. Curcuma is cucumber, right?
It's not turmeric.
I don't know. I really don't know.
It's turmeric.
Okay. Yes, St. John's wort is used for depression. It is an antidepressant. I don't know about its viral activity.
I have Hypericum perforatum.
Mm.
I just read here that it inhibits expression of HIV1 gene, so it has antiviral activity.
Okay. Any what about A and C? Anyone has looked them up? I feel like if you look them up, you're going to find all of them are going to have antiviral activity. Okay, A also has antiviral activity. Centella, I feel like it's going to have antiviral, but maybe probably anti-HIV activity might be the ruling out factor here. Someone confirm C? Okay, seriously, I feel like you see the problem with pharmacognosy, these things, the claims are as wide as they can be. So it's either we know for sure. So okay, okay, I feel like that is going to be a consensus, honestly, because if you're going to look them up, I'm sure you're going to find something that will claim Centella asiatica has anti-HIV properties. I feel like C is a consensus, right? Cannabis flowers, coca leaves, and poppy seeds are sources of cardiac glycosides, no narcotic alkaloids, pyrrolizidine
Yes.
alkaloids. Someone's talking?
I was saying yes to narcotic alkaloid.
Okay, narcotic alkaloids, yeah. Cardiac glycosides, we've done digitalis and digoxin, I mean. Tropane alkaloids, examples of tropane alkaloids. Maybe 3 or
Absopropyl, I
4.
don't know.
Atropine.
Yes, good. Pyrrolizidine alkaloids. Someone looks that up. 133. Which of the following is a source of natural contact insecticides? Catharanthus? No. Chrysanthemum, Hypericum, and Cassia. Catharanthus is anti-cancer. Hypericum, we've said it's antiviral, and we know for sure it is antidepressant. Cassia is senna, right?
Yeah.
Yes. So what is chrysanthemum? The local or the other common name for chrysanthemum?
Is it pyrethrum?
I'm not sure. I don't know, but probably yes. One 32. Please scroll down. All the following are sources of natural surgical dressings, fibers, and sutures, except the fibers of cocorus, seeds of gossypium, cocoons of bombyx, then camellia. Again, whether it's either you know you die.
It's definitely camellia, even if you don't know the others.
Yeah, I would die. What is camellia used for?
It's tea, right? Camellia is
Yeah.
tea.
Camellia is tea.
Yeah.
Yes.
Good. Okay, because I would have died there. The following is the most widely used method of extraction. Method for extraction of essential oils. We've done this. Extraction by means of volatile solvents, stream distillation, adsorption, or purified fat.
Definitely steam distillation.
Seriously?
Yeah.
I
definitely.
Why not B?
I remember from class. I don't know.
Why not B? I honestly would have from class. Okay, because I would have chosen B, but I don't know why. But okay, thank you. Steam distillation. The following are true about alkaloids, except Following are true about alkaloids, except they have nitrogen atom as a part of heterocyclic system.
Right.
They have, yes, they have complex molecular structure. They rarely exhibit pharmacological activity. Okay, definitely no. They are mainly restricted to the plant kingdom. I mean, where would alkaloids be? Okay. Yeah, the consensus, the straightforward answer is C. I don't think we should think through that anymore. 129, the following conform to pharmacological classification of glycosides, except pharmacological classification of glycosides, except beta glycosides, laxative causing glycosides, cardiac glycosides, and steroidal glycosides. Pharmacology. D? Gaius D? Why D? Rawlings D. Why D?
Mbona unastuka?
Hata mimi nashtuka. Mbona D? Because pharmacologically, I don't know, beta glycosides, I don't think it's a thing. Pharmacologically, at least. Yes.
When I don't know, there was someone who was taking us through pharmacognosy, and they told us when it's something has that bitter taste, bitter
Yes.
glycosides, they will have a carminative role, and also to improve appetite or to boost appetite, something of the sort. That bitterness has some pharmacological aspect. Maybe this, let me see, Rollins can say why he chose D.
Rawlings, why did you choose D? Because for me, I would have chosen A because laxative action, cardiac action, steroidal action, because being a steroid, it has steroidal glycosides, I think they're saponins, and they have a role because of the steroidal, I would say, value they have. So on Rawlings, why would you choose beta steroidal glycosides?
I have a question.
Yes.
Are there glycosides which are not steroidal in nature?
I don't know. I can't answer that. I can't remember my notes. Yes. I saw thiocyanates. Thank you, Musiva. Are glycosides.
This classification is based on therapeutic nature of glycosides. Based on that, we have cardiac glycosides, example, digitalins. We have laxative glycosides, e.g. Senna. We have anti-alpha glycosides, e.g. leucorides. And we have beta glycosides, quassia wood. So the one which is not there is steroidal.
Okay. Okay, that is new. Thank you. That is entirely shocking. Is the consensus on steroidal?
Yeah.
Okay, that is okay. So steroidal. Wow. The following are natural sources of pharmaceutical suspending agents: Acacia and Datura, Acacia and Astragalus and Angelica, Mentha and Centella. Suspending agents. So centella, we said it's T. No. Datura is Datura. I don't. Acacia gum. Can a gum be a suspending agent? Is acacia gum a suspending agent?
Yes.
I don't think it is.
Yes.
Okay. Datura, of course, no. I don't know about C. What is Angelica? Again, B makes more sense, definitely. But what is Angelica? Okay, someone look that up and type it in the chat, please. Which of the following cannot be classified as an organized drug?
The dried opium latex, right?
Yes. What do we mean when we say organized drug?
Remember last time we said organized drug is like whole plant of part of it, like roots, the rhizomes, the leaves, the fruits.
Okay. How much time do we have? 9 minutes.
Can we stop here and resume at 4?
Yes. Yes, we can.
Thank you so much.